and I'm delighted to be here in this beautiful new hospital. It's really stunning. I love the fact that the corridors are lovely and light and open. It's wonderful. I'd like to see more of it. Now, I was asked to talk to you about how the ideas about patient engagement have evolved, and say a little bit about where I think we're going with this. So I'm going to do that as briefly as I can, and forgive me if I go quite quickly, but I think that we're under some time pressure here. So I'll give you a little bit of a potted history, something about thinking that's developing on engaging patients in their individual care, something about quality improvement, and co-production and co-design. Now, certainly in the UK, and I think this is probably fairly universal, the foundations for this movement, I think it's fair enough to call it a movement, lie back in the 60s. In the 60s, there were some very influential writers looking at healthcare and the way it was organized and saying things could be different. So there were early challenges coming from academics, thinkers, and so on. But also, very importantly, we saw the first stirrings of a ground-up movement. In the UK, one of the most significant developments in the 1960s was a group called, I think they called themselves, they changed their name, but it was the Association for the Involvement of the Welfare of Children in Hospital. And they were very upset about the fact that parents were often kept out of the hospital when their children were hospitalized. And even if they were having fairly simple procedures like tonsillectomies, it could be very traumatic for children to be separated from their parents in that way. And they felt very strongly about this and launched a very effective campaign. And that it may not be the first, it's the one that I think was most influential in the early days. They managed to change opinion, change attitudes, and now, nobody would dream of asking parents not to be in the hospital when their children are there. But it took an awful lot of persuasion, arm twisting to get there. It seems extraordinary now, but it used to be the case that we thought that wasn't a good idea. So they succeeded eventually in their challenge. In the 1970s, of course, around the world, we saw the stirrings of the women's movement. And again, women's groups around the world promoted the idea of self-care, self-help. They also were critical of the way health services didn't really understand their needs and wishes. And at the same time, that was accompanied by more analysis, academic research, and so on, and the beginnings of what we call very clumsily, I think, the biopsychosocial model of healthcare. The idea that healthcare isn't just about technical interventions, it's very much about relationships and feelings and emotions, as well as all those other things. And of course, very affected by the social milieu in which people live. In the 1980s, the development of ideas about patient-centeredness and measurement, so measuring patients' experience, measuring patient-reported outcomes, that we're still trying to get that right, but the ideas really began, I think, in the 1980s. And in the 1990s, certainly across Europe, there was a big move to focus on patients' rights, and to make people aware of their rights and to encourage them to push for getting their rights. And we also saw the beginnings of ideas about new public management, new ways of managing public services, and a hope that introducing greater competition and choice, something that we, I suppose, are lessons we learned from North America, certainly from the US, that maybe that was one of the ways of giving a kind of encouragement, a kind of nudge to public services to improve the quality of what they were doing. The 2000s saw the beginnings of ideas about shared decision-making and the chronic care model, better ways of engaging patients in managing their long-term conditions. And now the talk is strengthening on things like co-production, integration of healthcare, and better coordination. I'm going to talk about where we are, I think, at the moment with some of those things, because these strands of discussion are continuing and we have not got there yet. But I'm optimistic. I think we're on the cusp of a real revolution in healthcare, which is going to be led by clinicians and patients working together in partnership. Somebody said that patients are the greatest untapped resource in healthcare. I think we're just beginning to realize the truth of that, and we're beginning to try to tap into that really important resource. So one of my involvements that Patty didn't mention in the introduction is that for many, many years I've been working with the Informed Medical Decisions Foundation, which is actually based in Boston. They've recently merged with HealthWise, which is another not-for-profit organization based in Boise, Idaho. But they work outside the US as well, and I've been helping them with that work. And they've really, I think, done more than any other organization to promote ideas about shared decision-making. But actually, very much what's gone on in parallel in Canada has been terribly important too. People like Annette O'Connor and Dawn Stacey in Ottawa, France Légaré in Quebec City, they've been real leaders in this, what's become a strong international movement to engage patients more actively in decisions about their care. There's a definition of it for you. I won't bother to read it. I think you're probably fairly familiar with the ideas. But essentially, the core idea is that in every medical decision, there are at least two sources of expertise. And what shared decision-making is bringing these experts together. So on the one hand, the clinician is expert in diagnosing diseases, in understanding the causes of disease and the likely outcomes, the treatment options, and the outcome probabilities. That's the clinician's expertise. And note, when I say clinician, what I mean is all clinicians, so doctors, nurses, therapists, and so on. A crucial source of expertise we couldn't do without. But the patient and the patient's family are experts too. And they also have a crucial source of expertise that we can't do without. The patient, and only the patient, knows what it's like to experience the illness or condition in their particular social circumstances. They, and only they, know about their own values, preferences, and attitudes to risk. So you can't make a good decision without drawing on both those sources of expertise. And indeed, if you fail to do this, what we argue is that the resulting decision is going to be of poor quality. It's going to be the main reason why we end up providing a lot of inappropriate health care. So bringing the sources of expertise together is what's important about shared decision-making. And the days of this poor passive patient who's told that they must shut up and just do what they're told, when we want your opinion, we'll give it to you, those days have to be over. We have to move on to a partnership between these two experts. And of course, this approach is relevant in many situations. There's one situation when it's not relevant. In emergency situations, what you want is for somebody to take a very quick decision on your behalf. But in almost every other situation that happens in every clinic and hospital and general practice everywhere, is a much more nuanced type of decision. And it's to do with selecting the right tests and treatments, managing long-term conditions, and advising people on how to prevent illness and promote their health. Shared decision-making ought to be central in all those settings. And in order to do it, patients need good information. They have very legitimate questions, like, what are my options? What are the benefits and possible harms of the different ways of treating my condition? And how likely are these benefits and harms going to happen to me? What can I do to help myself? And what can you do to support me? Those are the key bits of information that patients want. And the good news is that it is possible to give it to them. The reason they want it is that they have often very difficult decisions to make, difficult trade-offs. They're trading off often effectiveness of treatments, and this is a typical treatment. It's not any kind of treatment, but it's a very common situation. You have different types of treatments, lifestyle changes, medications, devices, surgical procedures, of varying levels of effectiveness, but often carrying also varying levels of risk. And often the more effective treatments are the riskiest treatments. So you cannot make a decision about which is best for an individual unless you know their attitude to risk, unless you know how they're going to make those trade-offs. And of course, just letting them find the information on the web, which of course many people consult Dr. Google. But when they do consult Dr. Google, they find a lot of information, some of it very unreliable, and with no guide as to how to decide what is worth taking note of and what isn't. And often the information that's out there is overly optimistic about the benefits of medical interventions, and it plays down the risks and side effects. So we have to balance that by providing good, reliable, evidence-based information. Patient decision aids can help with this. They're certainly no substitute for a good conversation between a patient and a clinician. But giving the patient something to look at home or a website to go and look at, to spell it out, to reinforce the messages, can be enormously helpful. And getting this right in the clinic, we've learned, involves really quite a lot. You have to have a system for inviting patients to participate in this way, which in some cases is new to them. You have to present the options, provide them information, help them think about the options in their situation, have a good discussion that helps them to deliberate among these options, and then finally make sure that you record what they want and help them implement it. Now, those are important skills that many health professionals need training to do well. The good news is that there's now a lot of evidence that this approach really works. And again, this Cochrane review was led by people at the University of Ottawa. Dawn Stacey, Annette O'Connor did the first one, Dawn Stacey led the latest. And there are now 115 randomized controlled trials showing that this approach can improve patients' knowledge, give them more accurate risk perceptions, leads to greater comfort with decisions, increased participation in decision-making, and good news for policymakers, it often leads to reduced costs because people, when they know about all the options, often choose the less invasive, the less expensive option. Now, we've talked a lot about this, we've done research and so on, but we're still not there when it comes to implementing shared decision-making. I have this strong sense that we are on the verge of this becoming accepted as the best way to practice, but we're not there yet, so we've still got quite a long way to go. And similarly, applying this kind of thinking to the management of long-term conditions is very important, and the recognition we have to have is that actually, with people with long-term chronic conditions, they're going to have to live with them for the rest of their life. And indeed, they do most of the care. People often talk as if health professionals manage chronic disease. Nonsense. The individual with a chronic condition sees a health professional on average about 3 hours in a year. The rest of the time, they are looking after themselves. So the goal must be to help them do the best possible job to look after themselves if we want to help improve health outcomes. And of course, chronic conditions are what costs our health systems the most money. About 70% on average, give or take, is the proportion of a healthcare budget that goes on managing chronic disease. This is where the untapped resource becomes most evident. You know, crazy to think that this is all in the hands of health professionals and we don't need to engage with patients. Of course we do. And this was pointed out very effectively by the people who developed the chronic care model, which I think is probably going to be familiar to all of you. The point they were really making is that patients live in families, and in turn in communities. They look outside the health system often for the kinds of supports they need, particularly people with long-term conditions. So the health professional's role must be to help them look outside, to help them get all the supports that they need from wherever they are. It means looking beyond traditional healthcare boundaries. And the way this is done is to have a care planning conversation between the patient and the clinician in a partnership where you share information, you share knowledge, the patient is encouraged to set their own goals, which are often very different from the clinician's goals. And then together you develop an action plan and implement it. And of course, this is not a one-off event. This has to be a cycle that happens regularly. So that means you often have to change the way you organise patient pathways to accommodate this kind of collaborative planning. And again, some good news. This is a Cochrane review that I actually led. There's not so much good research in this area as there is in shared decision making, but we found 19 trials, randomized trials, of this kind of approach, which showed that if you do this, you can improve physical outcomes, you can improve emotional or mental health outcomes, and you can strengthen people's capabilities for self-management. So we do know how to do it. Now we've got to get on and do it. And the third example I wanted to give you is about quality improvement. We've all, I think, everywhere been debating for ages, what do we mean by person-centered care, patient-centered care, patient partnership, etc., etc. I shared with people last night that I get a bit sort of fed up with those discussions now, because I often think we can go and have semantic debates forever, and it's just a way of putting off doing anything. This is one way of describing what we are trying to achieve: personalised, coordinated, enabling care that respects people's dignity and offers compassion and respect to patients. That was developed by the Health Foundation, an organisation in the UK. That's good enough for me. Now let's get on and do it. And one of the ways in which we've been doing it, of course, is trying to measure it. And there's a lot of measurement going on in all our countries. We recently published this book describing all the different ways of measurement. And we know it's important because the research, again, tells us it's important. The people who do receive better care or report receiving better care, they're more likely to adhere to treatment recommendations. They're less likely to die. A couple of studies have shown now from acute myocardial infarction, so they have better physical outcomes. They also use less health care because they become more self-reliant, and their care tends to be safer. So it makes sense again. We must do it. We're measuring all sorts of things: the processes of care, the outcomes of care, patient-reported outcome measures, as well as patient experience. And we're using both qualitative and quantitative measures. This is great. We need a mix. There's no one way of doing this. But the measurement is not enough. We publish the results. That's useful. Certainly in England, we publish results from every healthcare facility has to do a patient survey, of a number of patient surveys, actually. And they can also, there's web-based feedback and all sorts of things. All that is publicly available. But we know that just publishing isn't enough. In one remarkable hospital that I was talking about to some of you last night, they also publish the results for the individual senior doctors, and it's even on their website. And they put it up on the walls in the hospital so that patients can see and the doctors can see. And they publish ward-level data and so on and so on. But we've been doing this in England since 2002 on a regular basis. And this is an example of a question that is in all our national surveys. This is results from thousands and thousands of patients. And it's kind of depressing. It's a bit too flat. You can sort of see that there's a slight upturn. But really, I show you this to show that, talking about these things, debating them, publishing surveys is never going to be enough. We've got to do more to make this really stimulate change. We also found from the national surveys in the UK that people with chronic conditions, and particularly those with more than one, so these graphs show you the people with no long-term condition, people with one, and people with more than one, they report the worst experiences. So we're really failing, or at least we in England are, I don't know whether you are in Canada, but we seem to be failing those people who need our help most. So measurement isn't enough. And the way to improve things, as we now know, I think, is to engage patients in the improvement process. And I know there are lots of really exciting developments going on here. I've heard a little bit about some of them, and I'm really looking forward to hearing more this morning. Co-production is where we're now focusing our efforts. How can we engage people to really make a difference, to take the learning that we've got and put it into practice? And there was an interesting article published in BMJ Quality and Safety only a few months ago by Paul Batelden and his colleagues, really kind of spelling out. Co-production has been a sort of word that's bandied about and never very well described. And actually, if you want a description, I would recommend you go and look at it. He made the important point that healthcare is a service, not a product. So what we're trying to do is different from what might happen in the commercial world. We're really trying to, if you have a service, you involve the people who are receiving that service. Those people are playing a really important role in the quality of that service. So you must work together with them. And that's his, in a nutshell, his definition of co-production. But you need to look at the article to get the full flavour of it. And one of the ways we can do this is what we call experience-based co-design. This is an example of learning from designers, from people in art and design schools about how they go about designing and refining products by starting at the bottom, by tapping into people's experience of using services or products, by understanding how they react to these things in an emotional way as well as in a very practical way, and then building from the bottom up. And again, I heard some really nice examples of that going on here. But we will face, and we have to accept, that there are lots of barriers in the way that have to be overcome. The most important ones of these, I think, are attitudes. The attitudes of people working in the service. Patients' attitudes, on the whole, aren't a problem. If you offer something better to patients, most patients really welcome it. But health professionals are often nervous about doing things in a different way from the way they were trained. So winning hearts and minds is going to be the key to taking things forward to a true partnership approach. Time and resources always brought up as a problem, but it's possible to overcome that. Inflexible systems, we can change those systems. We don't have to feel they've got to be the way they always were. But the clinical culture, that's the most important thing. Clinicians need to want to do this because it's a better way of working for the benefits of their patients, and that's why most people work in healthcare. So to get there, we need a change strategy that's really going to work. And we know something now about what will work. We know that strong, committed senior leadership is absolutely essential. Dedicated champions, people who can think about this full-time, that's their full-time job, leading the work and supporting their colleagues. Active engagement of patients and families, of course. Clear goals, being very clear about what you want to achieve and spending time thinking about that before you launch into doing something. Building it into human resource structures, focusing on the workforce. The good news is that happy staff make happy patients, and happy patients make staff happy. So we've got to get both those things right. The morale of staff is crucial, and so is their training and skills. So it has to be supported by good training and education and resources. In the long run, I think this is the way we're going to make health systems sustainable. We're going to save money. But in the short term, we need resources to make it happen. And then, of course, we need to go round the cycle with more performance management, measurement, more feedback to see how well we're doing and to get even better. And the goal, I think, then, and where I hope we're going, and I'm pretty optimistic that we are going, is to cover all the bases. I described that in a book I published in 2011, getting patient engagement into everything, into the improvement of care processes, building health literacy, providing information, selecting treatments, strengthening self-care, making care safer. Again, patient engagement crucial in that. Patient engagement in research, in training professionals, and in shaping services. Now, I think we're about to hear some really wonderful examples of where you're already doing that, and I'm very much looking forward to it. But in the meantime, I'm very happy to answer any questions if there's any time and if anybody has any. Thank you very much.